Hello everyone, welcome back to my channel. So you already have seen the title of this video. That's the Carcinoma rectum MRI imaging. But before discussing the proper carcinoma rectum imaging, first it's important to understand the radiological anatomy of rectum on an MRI. So in this video, we will learn about the extent of rectum, rectal wall layers, mesorectal fascia, anterior peritoneal reflection, and venous plexuses around the rectum. So let's start. So rectum is the distal most 15 centimeter of GI tract. We radiologists follow the endoscopy perspective and we consider rectum as the distal most 15 centimeter of GI tract. So we are actually including this distal 2 to 3 centimeter of anal canal also in this definition. So this rectum is the distal most 15 centimeter and is divided into three parts. The low rectum, which is this, which is 0 to 5 centimeter in length. The mid rectum, which is 5.1 to 10 centimeter in length, and this high rectum, which is actually 10.1 to 15 centimeter. So what's the proximal most extent? It's this sigmoid takeoff. Okay, the point from which this sigmoid colon actually sweeps horizontally away from the sacrum. Away from the sacrum is sigmoid takeoff on sagittal images, and the point from which sigmoid projects ventrally away from the sacrum is actually the sigmoid takeoff on axial images. Okay, so the proximal most extent of rectum is sigmoid takeoff, which is identified on sagittal and axial images. What's the distal most extent of rectum? It's actually the anal verge. Where is anal verge? It's actually where the external sphincter ends. Now, what's called anorectal junction? This is the transition between the anal canal and the rectum, which is actually marked by a virtual line drawn from this lower border of pubis symphysis to the lower border of the sacral bone, and also by the upper border of the puborectalis sling. Okay, so this is the anorectal junction. Detailed discussion of anal canal and its sphincter's anatomy is already there in my previous video on perianal fistula. So briefly we are discussing it here. So dentate line actually lies in midway of anal canal, but not palpable by surgeon nor visualized by us radiologist. What we can see is this anorectal junction, which is 1 to 2 centimeter proximal to this dentate line. Okay, and already have discussed how to identify this anorectal junction. Now, what's anal verge? Anal verge actually marks the transition between the perianal skin and the epithelium of the anal canal. So, where there is transition of the epithelium of anal canal and epithelium of perianal skin, and we radiologists see this anal verge as the point where external anal sphincter ends. Okay, and the first plus minus 5 centimeter of perianal skin caudal to this anal verge is referred to as anal margin. Okay, so we are cleared of these terms: dentate line, anorectal junction, anal verge, and the anal margin. So pelvic floor muscle is actually this levator ani muscle, which is visualized here. Its continuation below is this puborectalis sling, which marks that anorectal junction. And this puborectalis sling below continues as the external anal sphincter. Okay. Internal anal sphincter is actually the continuation of circular muscle of rectum, and what lies in between the two is the intersphincteric space. Okay. So next is the rectal wall layers. Okay, the rectal wall layers. So there are three layers of rectum. The innermost is this T2 intermediate mucosa. The middle one is actually this T2 hyperintense submucosa. Because of fat, it is T2 hyperintense. And the outer one is this T2 hypointense muscularis propria. But the thing is that this three-layered rectal wall anatomy is appreciated only when there is submucosal edema. For example, in cases of radiotherapy in rectum patients. But in general, we cannot distinguish between these two layers of mucosa and submucosa on routine MR images. So it's basically a two-layered anatomy. The innermost T2 hyperintense mucosa and submucosa together, and this outer one, that is T2 hypointense muscularis propria. Why we are discussing these, you'll come to know when we'll study about the TNM staging. Okay. So the next one is mesorectal fascia. It's actually a thin fibrous structure. See this thin fibrous structure which is surrounding the rectum, the adjoining mesorectal fat, and few lymph nodes and vessels in this mesorectal fat. It's actually the visceral layer of endopelvic fascia, and MRF is actually the anticipated resection plane while performing a total mesorectal excision. What is TME? TME is actually the standard surgical treatment for appropriate cases of C rectum, where surgeon removes the entire mesorectal compartment, including the rectum, the adjoining mesorectal fat, and the perirectal lymph nodes along this mesorectal fascia. Okay. So what's the uppermost extent of this mesorectal fascia? This is rectum, and surrounding this is this mesorectal fat, which is covered by this thin structure that is mesorectal fascia. What's the uppermost extent? It blends with the sigmoid mesocolon. And what's the lowermost extent? It blends with the fibers of levator ani and puborectalis muscles. Okay. So next one is anterior peritoneal reflection. So basically, half of the rectum is half of the rectum is extraperitoneal, while the upper half is actually intraperitoneal, because visceral peritoneal lining is seen attaching to this red line. Okay, this visceral peritoneal lining is seen attaching to midway of midrectum after reflecting from pelvic viscera, and it is visualized as this this thin V-shaped attachment known as the Siegel sign. Okay, the Siegel sign. In male, it is seen as attaching from the tip of the seminal vesicle, and in females, it is seen attaching at this uterocervical region. So low rectum is actually entirely covered by this mesorectal fascia. But in mid-rectum, the mesorectum is covering the rectum on posterior and lateral aspects only, but on anterior side, it is covered by this visceral peritoneum. And in high rectum, the peritoneal lining extends along the anterior as well as the lateral aspects, and MRF lies only on the posterior aspect of rectum. Okay, so it's important to distinguish MRF from anterior peritoneal reflection, because MRF involvement is T3 disease, but peritoneal involvement is T4 disease. We'll discuss this when we learn about the TNM staging of C rectum. Okay, see in this image also. So this is the low rectum, which is entirely covered by this green structure. That's the mesorectal fascia. So if any cancer is involving this is T3 disease, MRF positive. But in upper half of mid-rectum, anteriorly it is covered by peritoneum. So if any tumor is involving here, it's T4 disease, T4A, but MRF negative. And in the high rectum, it's entirely covered by peritoneal lining on anterior as well as lateral. Just posteriorly, there is mesorectal fascia. And see, there is tumor that is involving anterior part also and posterior part also. So it's like T4A disease with MRF positive. Okay. So last one is the venous plexuses around the rectum. So these are the thin wispy T2 hypointense venous plexuses, and these are the mainly tributaries of inferior mesenteric vein that are running in the mesorectum along the rectum. And identifying these is important, because if these are involved by the tumor, like see here, there is tumor signal within this venous plexus. It's called involved by the tumor. It's called EMVI, extramural venous invasion, and it entails bad prognosis for the patient. Okay. So rectum is the distal 15 centimeter of GI tract. So this is the anorectal junction. This is the anal verge. Okay. This is the anal margin. Okay. And this is the sigmoid takeoff. Okay. So this is the sigmoid takeoff. This is the 15 centimeter, distalmost 15 centimeter of rectum. Now let's look at the axial images. So this thin wispy fibrous structure is actually the mesorectal fascia that is enclosing the mesorectal fat, and these thin wispy venous structures, see these are the venous plexuses. Okay, now this is the levator ani muscle, better visualized in the coronal images. Okay, see this one. So the levator ani muscle, this is the puborectalis sling, this is the external anal sphincter. Okay, and in the axial images, we have to localize the anterior peritoneal reflection. See, this is a female patient. This is actually the Siegel sign. See, there is this thin structure, this one. This is the anterior peritoneal reflection.
See you in the part 2 video of this video series. Thank you everyone.